نستكمل الآن الجزء الأخير من اليوم الثاني في هذا المؤتمر، ونتطرق فيه إلى موضوعات أخرى وأمراض متجددة. لتكون كويتيا يجب أن تكون مصابا بالسكر. هذه العبارة هي الأكثر تداولا بين أبناء الشعب الكويتي في الوقت الحالي. مرض السكر نراه متزايدا بشكل ملحوظ جدا في الكويت. عدة عوامل وأسباب كثيرة تدور حول هذا الموضوع. استشاري أمراض الغدد الصماء والسكر الدكتور وليد الضاحي سيناقش هذا المرض، فليتفضل مشكورا.
مساكم الله بالخير. أول شيء أشكركم على استضافتي. حقيقة مؤتمر رائع حسب المادة العلمية اللي شفتها في مجموعة المحاضرات. أي واحد ما يتكلم عربي هنا؟ أوكي. المحاضرة راح تكون بالإنجليزي if you don't mind، وراح أتكلم عربي إنجليزي. Okay. So my job today is to talk about diabetes. And as you know, diabetes is one of the problems that's happening all over the world. عشان كذي أنا حطيت diabetes everywhere. It's really everywhere. طبعا if you look at diabetes عبر العصور, it's basically a disease that's not new. Diabetes موجود من آلاف السنين. If you look at the different cultures, and the Greek, the Latin, the Egyptians, it's been mentioned. The Greek يقولون diabetes, the Greek passing water like a siphon. So هم يعرفون ذاك الوقت ان السكر يسبب something called polyuria اللي هي passing urine. Mellitus coming from the honey, and later they joined diabetes mellitus to be one word as the diagnosis of diabetes. In Egyptian they also mentioned diabetes, and هذه الصورة هي صورة الفرعون حتشبسوت who died of diabetes. And this is proven recently when they took their cadaver and they opened it and they tested her and they found that she had multiple abscesses or signs of diabetes and chronic disease. So this is a disease that's been there for a long time. Okay? And the Hindus, long time ago, they used to notice and اللي عنده diabetes when they pass urine, النمل يجي على اليورين. And this was actually one of the things that have been used over the years to distinguish between patients who have diabetes and patients who don't have diabetes. But they asked the doctor يقول له قول بالربع, and then they see the ants. If they come to the urine, it's actually basically diabetes. So very interesting over a long time. This physician, okay, in the 17th century, أول واحد خذ الستيب actually to taste the urine. And this guy actually tasted the urine and was diagnosed with diabetes according to the taste of the urine. And this was the method that's been there for around 100 to 150 years. When the Catholic they taste the urine to find if their patient have diabetes. Alhamdulillah, نحن بذاك الوقت. Okay. This is just a picture to show you the dramatic things that happen to diabetes. هذه طفلة. This is the same child. هذه 2 months later after the introduction of insulin in 1922. Look what happened to her. Usually the kids with type 1 diabetes die within a few months. And when insulin came in 1921, actually it was a miracle. So these kids lived up to 20 and 30 years. And later with time, we know that they live even more. This is one of the early ampoules that have been used in the treatment of diabetes. شنو يصير عندنا بالخليج العربي؟ We know مثل ما المقدمة قالت إن احنا we have very common disease, diabetes considered to be a very common disease in our area. And if you look at the GCC, this is basically a family pedigree from Saudi Arabia, and you can see people who are affected in red. And I'm happy to go through it just to emphasize that look at the third generation, you still see diabetes. But this is a very alarming sign that we see diabetes now in younger generations. We see diabetes in people who are in the 20s, teens, and even, very early. We don't used to see type 2 diabetes very early, but nowadays we see in our generation new type 2 diabetes comers that's happening in our generation. This is from the GCC, هذه مجلس التعاون الخليجي. Diabetes in general in our area is between 1.9 to 2 in 10. So كل 10 موجودين, there probably around 1.5 to 2 persons will have diabetes, and this is a very also alarming thing. If you look at the rate of inactivity في الخليج العربي, you can see in female, Saudi Arabia, in United Arab Emirates, in Oman, around 80% they have inactivity. On average, 71% of our people, they are inactive, and we see this. ما عندنا شغل غير بيت دوام دوانية, and في الديوانية is just sitting, eating, playing cards, والحريم just they watch Turkish series. Okay. This is the top 10 countries of the highest prevalence of diabetes in the world. You can see here, this is in 2003, Emirat, Bahrain, the Kuwait, Oman is one of the top 10 countries of the highest prevalence of diabetes. فأعلى دول العالم نصهم موجودين في الخليج العربي, and the updated literature shows the same. This is in 2007, the Emirat, Saudi Arabia, Bahrain, the Kuwait, and Oman. And these are the average percentage, the prevalence of diabetes from 19 to 13. And in 2025, the same thing, the 5 persist there. Okay, with the Kuwait, it will go up to 16% of our population. If you look at data that the GCC actually took from small studies around in the Arabian Gulf. The study اللي فاتت كانت من International Diabetes Federation, and they did it on a sample of around 1,000 patients in each country. But these are, if you look at the all papers coming from the area, we can see that it goes up to 32% in the United Arab Emirates, with the Kuwait 22%. Saudi في أماكن they reach up to 40% of the population. They have type 2 diabetes. So this is a very common disease. ومثل ما قالت مقدمتنا, إذا ما عندك سكر أنت ما أنت كويتي. And people actually take it as a joke. يعني بالديوانية قاعد يقول فلان أنا عندي سكر يلا صرت كويتي. And it's not really a joke. This is a very harmful disease, a disease that kills people, and people don't take it. They take it very light. السؤال, next سؤال اللي هو شنو هو? Why we are concerned? اليوم, if you tell any patient that you have diabetes, there is no concern by the physician or by the patient himself. الدكتور يقول له ما في شيء, لسه عندك السكر 9 8 يمشي لك شوية وخلاص. That's what's happening. لكن in the real time, actually we have to be concerned about this disease. We have pills and insulin to control it. So what's the big deal? That's what people think. أنا أخذ دواء وخلاص وعلى الله شفاي, I will be fine. But actually, diabetes is more than this. If you look at the total mortality comparing diabetes to other diseases, to cancer for example, diabetes is killing more people than cancer, all-cause mortality and major cardiovascular disease. If you look at cardiovascular disease, it's actually going down. وليش قاعد تنزل؟ لأنه we have CCUs, catheterization, early detection of MI, treatments for thrombolysis. All this make cardiovascular mortality goes low. But diabetes, with all what we have, it's the first killer in the world. It kills people more than all of these. But it states it kills 1 American every 3 minutes, a new case diagnosed every 40 seconds, more deaths than AIDS, breast cancer combined. If you look at the states, all the money goes to AIDS and breast cancer. But look diabetes actually kills more. And the average life expectancy is 15 years less. So this is a disease that we have to get concerned about. We have to change our look at this disease to be, more serious. If you look at, complications with diabetes, microvascular or macrovascular, small vessels and big vessels complication, you can see all kinds of complications. You don't have to even read them. If you have diabetes, your numbers goes very high. Chronic kidney disease, foot problem, iodine, chest pain, congestive heart failure, stroke. Just to have diabetes makes your risk actually 3 to 4 times more in all complications. On the other hand, it also takes the money of the governments. For the states, this is 1994, 113 billion goes to diabetes, 35 billion goes to cancer. This is the cost of patients. So it's even more than cardiovascular disease and mental illness. So 80% it is a preventable complication, because most of these costs goes for people who have complications. We know over time that when we lower our glucose, things become better. And this is now a standard of care. Not anymore we accept patients with higher A1C and we just tell the patient, as I told you, nothing happened, just go around, and then we wait on patients till they develop complications. Lots of complications, as you know: blindness, diabetes, the leading cause of blindness; kidney disease, diabetes, the leading cause of end-stage kidney disease; nerve damage, amputation, diabetes is the leading cause of amputation; loss of circulation in the arm, heart attack, strokes, and heart disease. All of this is a result of a chronic diabetes complication. And these things basically cost a lot. If you look at the cost of diabetes, it goes mainly with the long-term complication. So the diabetes equation is complications equals money. And unfortunately, our people who are in power don't understand this. When we talk about prevention, when we talk about programs to prevent diabetes, they think, this is not important. Let's spend money on cancer, for example. And this is one of the things that our people don't understand. Now, when we lower the HbA1c, which is the average glucose that we follow the patient with, what happens to the patient? And that's something I usually tell my patients. If you lower your A1c by 1%, what does happen? مرة الناس يقولوا دكتور شو سوي؟ سكري 8 بيصير 7 شو الفرق؟ I will stay this. I will not change. And we all have family and we all have things that happen the same. Look what happened. If you lower 1%, you decrease 37% eye disease and kidney disease. I'll change here. Amputation by 43%. Death related to diabetes by 20%. Heart attacks around 14%. And stroke by 20%. So this is something serious, and we can do it by lowering our glucose. So the importance of getting the message to the patient that lowering your glucose is actually going to help you. This is very important. With time, with all guidelines, with all big trials, we know that if you lower your diabetes, it's better. Before we used to diagnose diabetes by 7.8. Now we diagnose diabetes by 7. Before we used to diagnose pre-diabetes by 6.1. Now we diagnose it with 5.6. So you have to look at your patient, and we know that all the guidelines and all the studies looking for a lower glucose. Now, what we are really doing in our clinics, in our life, we understand that this disease is important. So what's happening in our clinic? If you look in the world, this is China, Canada, United States, and Europe. You can see that in Canada, 51% are having average glucose of less than 7. In China, 68%. And the reason it's high because China, they use higher cutoff. And هم ما يمشون على international guideline, which is 7, they use 7.5. That's why their number is higher. Canada, it's high because it's a social system. They can provide lots of drugs free, not like in the States, but you know, on average, 37 to 50% of people are actually on control. What happened in the state? This is a study in 1999. You're looking at U.S. adults with diagnosis of diabetes. You see, if they are having diabetes alone, the control is around 73%. And the reason is because they are early in the disease, they can really control it. But what happens if the disease goes late? If you use insulin, the rate of control is low, because this disease is very difficult to control. Even when you use insulin, only 26%. The overall is around 45%, leaving around 55% of patients are out of control. طبعا احنا بالكويت we don't know our clinics. احنا بالكويت we see patients with A1C, which I never saw in the States, for example. 20, 16, 18 HbA1c, which is, you know, حلم انك تشوفها في North America. But here we see it on frequently when they send it to us in the tertiary. Let's talk about the pathophysiology of diabetes, because it's really complicated and there are some newer things that are happening recently. We know that obesity is one of the major pathophysiological changes in type 2 diabetes. And it's not any obesity, it's a central obesity that's related to insulin resistance. Look what happened to diabetes and mean body weight. And this is the prevalence. And you can see both of them, they go together. So diabetes and obesity, actually they go together as an epidemic all over the world. This is diagnosis of diabetes 2000 to 2004, and this is again obesity, and you can see the same rate increase in diabetes and obesity. This is a study done in Kuwait in 2007 looking at the obesity in children. And this is a very interesting study. Look what happened. This is here, this is female and male, and this is, you can see, between 22.8% in male and 25.7% of the population, they have obesity of our children. Now, if you go back to our Kuwaiti community, لما تفتحون مثلا مجلة جريدة الوطن تشوفون صور المقهوة القديمة اللي يحطها في منتصف المجلة أو الجريدة، تجد أن الصور القديمة اللي بالمدارس they all thin. Now, if you go to the schools, they are all كرشين. But this is real observation, and there are many reasons for that. And this is what's happening. This is 10 to 13 years, around 26 to 23%, which is very high, you know, among the children in the world. But this is the most important. From 5 to 9, we still have 13 to 15% obesity. And this is very alarming. You know why? لأن هذول اللي من 5 سنوات إلى 9 سنوات اللي responsible for their eating is their parents. But there's a problem in the family. هني اوكي صار تينيجر وراسه يابس وما تقدر تقول له شنو ياكل وشنو ما ياكل. لكن here you actually train him to be like here. So there is a problem in our society, in our culture. اليوم الأم عشان تقول حق ولدها حل الواجب أجيب ماكدونالدز. Very common. أو مثلا تبي تعطيهم reward توديهم إلى fast food chain, which is very important. If you look at a prevalence of impaired glucose tolerance in type 2 diabetes, this is a study in 2002 in New England Journal, and you can see impaired glucose tolerance between 25 and 21%. Look at this child, which is very common we see in Kuwait, and around 4% this cohort, they have type 2 diabetes. So this is very common. This is 2 burgers. Burger من 20 سنة قبل كان في ومبي أول أيام ما نزل البرجر الومبية كانت تمام. And we don't eat it all the time. وأشياء راح تذكرون بس. Okay? And look what happened to the burgers. The calorie here can around 300. The average calorie in the new burgers between 600 and 1,200. So look, and what happens? They challenge the kid. بيقولوا له نعطيك ادفع 100 فلس and you get the bigger meal, bigger fries. Can you eat it مثل KFC يقول لك تحدي تعال تحداني and you give him big meal and you eat. This is all ways to actually ruin our children. This is the price of McDonald's from 1960 to 1999. And this is the calories and gram of fats. And you can see the amount of calorie. Triple من 60 إلى 1999. So تدفع 100 فلس, you get more calories, you get more harm. So this is what's happening with the food chains. They're actually changing, not even, you know, the kind of food we eat, they're changing. ذوق الأطفال now, they don't taste other food because the brain is used to saturated fats. And this is one of the issues that these fast food chains do. They add lots of materials. وذلك تجد الطفل يحب ماكدونالدز ما يحب برجر كينج والكلام هذا, and they used to the taste and they get hooked to it. And this is one of the things. Now, central obesity is basically the issue. هذا patient with type 2 diabetes, هذا patient with normal abdomen. You can see the white thing is visceral fat. And this is basically what makes diabetes. Now, visceral fat is considered an endocrine organ. It's not any more fat. This is an organ that produces a milieu of what we call adipokines, or cytokines produced by the fat. And these adipokines, which is TNF-alpha, IL-6, adiponectin, they all contribute to the development of diabetes. That's why our obesity is central obesity. الأمريكان تلقى كل obese. Our obesity تلقى ريول ضعاف أو الكرش is big. And this is basically central obesity. And this is a study to look at the correlation between insulin sensitivity and central obesity. And you can see central obesity is the only fat that actually associated with diabetes. But subcutaneous or lipolysis ويسوونها طباعة تجميل does not improve basically diabetes at all. Okay. So central obesity is associated with too many changes. كل واحدة بها lecture. Broad thrombotic state, type 2 dyslipidemia, genetic background, hypertension, cardiovascular disease, and low-grade inflammation. And all of this goes with what we call insulin resistance. Type 2 diabetes and low-grade inflammation is one of the major, actually, area of research that lots of things happening with it. Now, the second abnormality is beta cell dysfunction. Well, that's what's happening. And that's why we see our patient, they start with a normal glucose and they develop insulin resistance. The pancreas will compensate by producing more insulin, but at one time the pancreas will fail. So when the pancreas will fail, you develop diabetes. And that's why people start very early in the disease. Diabetes does not start within a minute. It starts for many years where you get failure of the pancreas. But this is a study to look at all kinds of treatments of diabetes, and you can see with time, all مريض type 2 diabetes, whenever you give them insulin, diets, or urea, they all gonna fail with time. And that's why كل مرضانا they will develop insulin deficiency, and later they will need insulin later in their life. Now, incretins is one of the new things that I wanted also to let you know about, which is happening in the diabetes field over the last 5 years. Incretins are hormones called GLP and GIP produced by the gut. Well, these hormones are there since 1890. وما حد كان يعرف what are these, وإحنا درسناهم أذكر بالفسيولوجي. They are just produced by the gut. But around 18 years before, someone discovered that these hormones basically they communicate with the pancreas. So هذول link between our pancreas and the food. So when you eat, the gut will tell your pancreas, we have food, bring me insulin. Okay? So when you get food, you reduce these hormones, they go to beta cell that produce insulin, postprandial, and they decrease the gluconeogenesis. So basically, these are new hormones that actually discovered in the pathophysiology of diabetes, and now we have modalities to treat them. They have lots of functions, secreted from the gut, enhance beta cell, increase beta cell response, they decrease the beta cell load, means they make it work better. Okay, they decrease alpha cell, so they reduce the production of glucagon. مثل ما تدرون الglucagon increase the sugar, while insulin decrease the sugar. So these are two counter-regulatory hormones. And they work on the liver to decrease glucogenesis and also help to regulate the gastric emptying. And finally, they do promote satiety. So these are new drugs now available. They actually help the patient to reduce glucose and reduce weight in the same time. And they are very exciting. Well, now, the idea of these drugs, it came when actually this scientist found this hormone and actually looked at the idea. This is intravenous glucose and this is oral glucose. So they bring the same patient, يعطونا IV glucose ويعطونا oral glucose. Look what happens. This is insulin. So when you give oral glucose, your insulin release is much higher than when you give it intravenous. وهذا الفرق احنا سميناه incretin effect. When you look at diabetic patients, you see they don't respond very well. فعندهم loss of incretin effect. And this is now one of the pathophysiology of type 2 diabetes. Again, insulin resistance, insulin deficiency, and now loss of the incretin effect. شو يصير؟ This is هذا GLP هرمون نفسه وهذا time. So when we give it, this is what happens in normal people, goes up and down. This is impaired glucose tolerance, and this is what happened in type 2 diabetes. So they have a lower response with the GLP when you give a meal. So this is also known. This is type 2 diabetes, this is glucose, هذا control, هذا type 2. What happened when we give them the hormone and GLP, the response goes back to normal. So when you give the hormone to these people, actually their insulin response normalized like people who don't have that. This is again to show you when we infuse this hormone, glucose goes down, C-peptide, which is replicate the insulin release will go up and glucagon will go down. So this is basically the new class in the treatment of diabetes, and we are very excited about it. When we actually incubate beta cell with GLP, they actually live more. So this is evidence in animals now that these hormones may prevent the development of diabetes. And this is there is lots of research now going on the prevention of diabetes with these. These are Zucker fat rat, these are rat genetically made to look like type 2 diabetes, يعني rat مكرش, basically. So when we give them the GLP, the beta cell mass is more, the beta cell proliferation is better, and the beta cell don't die very easily. So this is a very exciting finding that these hormones maybe in the future will actually prevent our diabetes loss. We have an injectable forms and we have the oral forms of these incretins, and this is what's this? Yes, this is the Gila monster, which is the first time we found the exendin-based therapy, which is GLP extracted من لعاب. They found it from the salivary of this wonderful lizard, and basically now it's a drug that's available for our patients to be used. Okay? So when we talk about diabetes, we have to talk about combining treatment of these pathophysiology. فاحنا عندنا أكثر من pathophysiology, insulin resistance, insulin deficiency, قلنا incretins. But when we want to treat, we have to actually look at all of them. In the past, we have diet. How many minutes I have? 2 minutes. In the past, we have diet, insulin, and sulfonylurea. اليوم عندنا lots of drugs. Why are drugs available for our patients? Who fortunately, most of them are available for free for the government, even the newer drugs. Now, hypoglycemia is one of the major problems that we face with diabetes, and it's one of the issues that actually happens recently. قبل احنا عادة we are very aggressive with our patients, we treat them very, very aggressively, but we know now that hypoglycemia is very harmful. This is, the frequency of hypoglycemia and symptomatic during, the study. This is on insulin and oral, an all patient. You can see people with insulin, they have very high hypoglycemia. Just for the sake of time, I will go with this study. This is a big study, a cohort trial looking at people to get them to an A1C of 6.4, which is very meticulously controlled. The شنو صار لهم? They start dying more. So we now know that even getting the patient to a very low glucose, it's harmful. So we have to be careful about treating the patient. So which treatment to use and when? We have, as we said, increase in glucose uptake. We have 2 drugs that work, alpha-glucosidase inhibitor and which is metformin. We have increased hepatic glucose production. There are drugs to work here. Insulin deficiency and insulin resistance. So when you actually look at your patient, you have to decide when. And the problem with diabetes, as we said, that it starts very early. Do you know what is this? Anybody knows? Yes. So this is a patient who was a child with acanthosis nigricans. Acanthosis nigricans احنا نشوفها يوميا. You can see it even in TV. المغنيين الامتحان تلقى عندهم سواد هني. Our famous singer. بالإمارات الجسم كان عنده 2 after the bypass it actually severe. The بيشعر عنده. The children who are obese, you see blackening of their neck. This indicates insulin resistance. And this happens very early. We call it pre-diabetes. And our job now, خاصة بالكويت, is actually to find people in pre-diabetes stage and try to treat them. Unfortunately, we don't have evidence that we can use any modality of treatment up till now, لأنه ما في big studies. But the most important thing is to start to think about diabetes when you have someone who are at risk of diabetes, and we treat them with lifestyle modification. Then treatment, insulin resistant goes, insulin secretion goes down, and then you get insulin secretion goes down and beta cell die, and then hyperglycemia happens. Lots of drugs. Basically, we as physicians who treat diabetes, we try to choose of one of these drugs available according to the patient's stage of disease and situation. قضية مو like أي patient تعطيه the same drug as many doctors do, because you have to tailor the treatment to your patient. Thank you. You have questions?
انت ركزت على GLP-1 بس شو يعني what about كيف يعني شو تأثيره في diabetic patient?
Yes, GIP actually it have no big role because it was tried actually. There are some deficiency in GIP in patients with type 2 diabetes, but replacing GIP did not improve beta cell absorption. So that's why all the research moved to GIP. But GIP برا الحسبة. We don't use it. تفضل.
دكتور بخصوص العلاج يقول يشيل المرض نهائيا يحفز البنكرياس طيب مرة نسمع الحين في دعايات لأنه هل هذا صحيح ولا؟
يعتمد وين سامع الدعايات؟
تجي على الايميل وعلى
أول شيء there is nothing when you are diabetic there is nothing to cure you, even bariatric surgery. Okay, I mean the bariatric surgery موجود. The bariatric surgery will actually revert diabetes to normal, but does not cure you from diabetes. وإحنا قاعد نشوف المرضى والبariatric surgery after 2 years they come with diabetes again because they get loosened up with their food. So losing weight is one of the things that may reduce your glucose down to normal, and it depends also on the stage of the disease. If the later stage of the disease where your pancreas خلاص is dying, you're going to control when you have something like bariatric surgery. But the other modalities كلها basically business. الدراج اللي سمعنا عنه recently بالإمارات مع السوداني، الإمارات سحبت ترخيصها and it was not right. Something, and imagine someone who actually tell the people أنا عندي this drug wonderful واخر diabetes class 6 أشهر and have no single paper on it. Doesn't make sense. These people are they play حتى اللي هو يسمونه stem cell transplant, also all اللي موجود في Germany, موجود في أوكرانيا والهند والصين. It's all out of law and it have no regulation and basically it have no proof that it's cured diabetes. Yes. Waste of money. Alright.
What about insulin-resistant diabetes, especially in very young patients and television shows that we watch? When they lose weight, they tell them that they don't need to take their medication anymore.
When you are diabetic, or through the treatment, but when you are diabetic, the basic treatment for diabetes is metformin, which is a drug that reduces insulin resistance. So when you are morbidly obese and you lose weight, you still need to keep on metformin. And this is a standard all over the world. And this is well known. Losing weight may control your diabetes. You may stop insulin. You may stop many drugs. There is nothing wrong with that. وهذه الفكرة اللي الناس ما تفهمها، إنه يقول لك والله دكتور أنا من تعطيني أوبر خلاص معناها أنا انتهي. That's not right. When you actually improve your lifestyle and reduce your weight, we stop معظم البariatric surgery patients. We stop their insulin. The oral, we stop the sulfonylurea, which is the one that stimulates the pancreas, but we always keep the glucagon.
دكتور يعطيك العافية. عندي بس سؤالين. First of all, you put a lot of blame on fast food, and I have a right to ask you, why don't we see that increased care of diabetes in Western population, in spite that they are exposed to fast food much more and for long years ago, before us, يعني.
تقصد إنه why it is not higher than us?
Yeah.
طبعا diabetes in our area probably we have a genetic, background. The kind of obesity we develop is different than the kind of obesity developed in North America and Europe, which is central obesity. And the central obesity is the one that causes diabetes. Now, what's happening in North America and the States, they are actually fighting these chains. صح تشوفهم وايد، لكن they are fighting. الآن في قرارات في بريطانيا ومعظم دول أوروبا أن الفاست تشين ما يسمح لنا يفتح على بعد نص كيلو من أي مدرسة. الآن في أوروبا الماكدونالدز وغيرها ما يعطي سناك كوكي، يعطي سناك فيجيتابلز. بطلوا البيبسي والمشروبات هذه يعطون حليب أو عصير. If you want to buy, you have to buy it. So they are trying to change. واحنا نتمنى، يعني تكلمنا في الموضوع وايد ان المفروض الفاست تشينز في الكويت يصير عليهم ريستريكشن. الدليفري ممنوع يفتحون داخل المناطق، لان المناطق اليوم الجمعيات يعني كل جمعيه فيها 3-4 فاست تشين which is not right.
السؤال الثاني, do you have any comment about gestational diabetes in our population?
Yes, gestational diabetes is also very common in Kuwait. طبعا studies on gestational as numbers ما عندنا, but we have a good amount of gestational people, women newly diagnosed. طبعا غير اللي هم diabetic, they develop, they are pregnant with diabetes. So we have a big population actually. معظمهم they are followed in الصماء, and some of them are followed in جامعة والغدد. Gestational diabetes also develop in people who have genetic background and obesity. And also gestational diabetes by itself is a risk for developing diabetes. A woman who developed gestational diabetes, she had a 50% chance in her life of developing type 2 diabetes. والمشكلة اللي عندنا إنها تخش gestational and she doesn't know this fact. And nobody tells her this fact. But she developed diabetes a few years later without prevention. So this is something very important.
في دراسة جديدة تظهر أن type 2 diabetes is showing in very young kids these days. What is your comment about that?
طبعا أنا وضحت لك هنا إن في البيدجري, this is Saudi family, around 20% of the family below the age of 20 they have diabetes. So genetic background, obesity and lifestyle. واحنا اليوم قاعد نشوفها كل الكيدز اللي تشوفهم عندهم hackathons and there is one actually fellow, she did this في البرازيل, good paper, خذت كل school kids around maybe 3000 وخذت samples من السكن and they follow the patient and the rate of diabetes is huge in these patients. فthese type 2 diabetes احنا كنا نشوف قبل ما نشوف الحين we don't have a certain number في الحين registry going on for children with diabetes لكن we are seeing these patients now very frequent من 8 سنوات وفوق usually.
شكرا دكتور، يعطيك العافية.
حياكم الله، مشكورين.